Yeah, Professor Sabbagh is really one of the most eminent dementia professors and neurologists in the United States. And if there is anything about dementia in USA across the pond, Professor Sabbagh is the one to talk to us about. Over to you.
Thank you, Professor Tabet, and hello. I have 20 minutes to go through a whirlwind on the therapeutic side. Clearly, a lot of things developing in the US are developing also in the UK. The discussion, of course, at this moment is really about DMTs and disease-modifying therapies, and really about monoclonals, which has really dominated. But if you look at the history of therapeutics in Alzheimer's, it really follows that purple line. But ideally, we would love to combine symptomatic and disease-modifying to be the blue line. And these are the kind of the aspirational and theoretical approaches. People think there's nothing going on in this space, but in fact, there have been over $40 billion of investment, particularly in the phase 3 space. And this is the list in the last 20 years of just phase 3 programs that have come and gone. And, you know, every year we come to these conferences and we say, any day now, we've got the next big thing. And so this has clearly been an area of unmet need. Every year, a group, Dr. Cummings, I was actually on this paper, publishes kind of a snapshot of everything going on in the therapeutic space. If you look at the top third, you see this is the monoclonal antibodies, particularly in the inner circle, that's phase 3. But you see there are a lot of molecules kind of in development as well in the phase 3 space. So it's not just the monoclonals. In fact, there's a huge number of trials going on, over 75 trials and 75 products. If you follow the Alzheimer's monoclonal story very carefully, you understand that at the top of this discussion is the understanding of the biology of amyloid. That basically amyloid is cleaved, and in cleaving from you're changing the pathway from an alpha secretase on the left to a beta secretase on the right. And the difference, of course, is that alpha secretase fragments, the P3 and soluble APP, are cleared, but the beta secretase fragments are not. And that's what accumulates, and that's what happens. Is so we understand that if you going from left to right, you cleave the molecules using secretase inhibitors, you get a monomeric A beta, but it's not until you get to the oligomeric species, that's the yellow and then the blue, that the brain starts to react. So in monomeric A beta is a nascent protein, the brain doesn't react, no microglial activation, no inflammation. But only when you get to the oligomeric species do you see the brain start to react. So the question has been and continues to be, do you go for production-based approaches, meaning prevent the production of Alzheimer's, of amyloid, or do you go for clearance-based approaches, or do you do neither? And the reason this is important is that both approaches have been looked at. Both at the bottom, the monoclonal antibodies and vaccines have been clearance-based approaches, and on the left-hand side, the production-based approaches have been developed. What we do know is that the production-based approaches, for the most part, have failed. So we don't go for secretase inhibitors as much anymore. Monoclonals have been in development for 20 years, and we are still seeing them pulling through. So we'll talk about that. What you have to understand is that the whole story of aducanumab starts 15 to 20 years before. The first discussion about this occurred in the vaccine AN1792, and we used an active immunotherapy, an active vaccine. And it worked great in mice. We cured Alzheimer's. In 20 years ago, I would have said we have cured Alzheimer's disease. This is the vaccination before on the left and vaccination after on the right. And we clearly thought we had removed amyloid. We thought we had cured Alzheimer's. It goes into a phase 2 trial. They enrolled 360 people in 6 weeks. You all do trials for a living. You know that's a huge number of people enrolled 6 weeks. Well, after 3 months, they started hearing about vasogenic edema, and by 6 months, they had stopped the study because there were 18 cases of encephalitis and 5 deaths. And this really kind of got people a little scared. But the fact is when you looked at the autopsy material, you saw that the brain worked. The amyloid was cleared. You see the bottom panel, there was clearly much less amyloid than the top panel. So the concept of removing amyloid was clearly something that needed to be considered. Hence, we move into the passive immunization phase. This is the monoclonal era. And aducanumab is not the first, it's the fourth. drug, the monoclonal antibody. And if you actually look at bapineuzumab, which was the first of the big ones, this was a monoclonal antibody targeting against the plaque itself. You see that amyloid was removed very, very clearly. I can't believe I flipped that upside down. I didn't even notice that. Okay. And then the amyloid was removed in the bottom left-hand panel. The amyloid was removed, but there was no clinical effect. And people say, well, if you remove amyloid, why was there no clinical effect? My theory is, and I was on the paper, the New England Journal paper, is that the phase 1 trial was 5 and 10 milligrams per kilogram, and the phase 3 trial was 0.5 and 1 milligram per kilogram because we got scared from the vasogenic edema. So I think we just dosed it too low. You looked at other monoclonal antibodies. This was the solanezumab, which was looking at the target of monomeric A-beta, and it showed a little bit of change, no removal of amyloid, and but did not meet statistical significance, and they just decided to not move forward with it. Hence, we get into the era of aducanumab. Aducanumab is a unique monoclonal antibody insofar as it was taken from natural immunity of human beings. So whereas most other monoclonals are actually derived from mice, this one was actually derived from elderly people who had natural immunity to amyloid, and they extracted it and purified it. In their phase 1 prime study, and this is what got everybody excited, is this paper here in Nature. And understand that you don't publish anything clinical in Nature ever, ever, ever. And so this was a big deal to get a thing published in Nature. But if you're going from left to right, in the left-hand panel, you saw in a dose-dependent manner that the higher the dose, the more amyloid was removed. That was so you see the dark blue line is significant removal of amyloid. In the right-hand panel, you see in a dose-dependent manner that the higher the dose, the slowing of the rate of decline, both in the CDR sum of the boxes and the mini mental state exam. So this was the first indication that we had what's called directional concordance. In other words, the direction of the amyloid removal and the direction of the clinical signal went in the same direction. Before that, we either had a clinical signal or an efficacy or an amyloid removal signal, but never both in the same direction in a dose-dependent manner. So, and this is the graphic depiction. You see at the top, there's amyloid not removed in the placebo group, and on the bottom, you see there's no amyloid left in the brain. Then they went to the controversial phase 3. This is what everybody is getting their bee in the bonnet about. So they see that in a dose-dependent manner that the high dose, 10 milligrams per kilogram, that's the actual purple line, actually slowed the rate of decline on the CDR. CDR is a clinical instrument. So the fact that a blinded rater could see that there was slowing in the rate of decline by more than a half a point shows that there was a significant clinical impact. And then the right-hand slide showing a directional direction of the same, but didn't meet its statistical endpoint. And so this is what they filed on. And the controversy about this is that the FDA said, the FDA made their approval based on this, that you can remove amyloid and therefore it hits its biological target, and therefore the clinical efficacy signal has yet to be determined, but it meets its endpoint in hitting a biological target. The controversy is people are like, well, it didn't work because one study was positive left and one study was negative right. But in fact, it just didn't meet a statistical endpoint on the right. And so the question has been, should they have approved it or not? I'm in the group camp that says strongly yes, because like Professor Tabet, I take care of patients for a living, and they want solutions and they want them now. And we can't wait 20 more years for solutions to emerge. So this is where the controversy is. Now, before we get excited about aducanumab, you understand that there is risks, and there's something called ARIA, amyloid-related imaging abnormality, and the higher, if you're an APOE4 carrier, the higher probability of getting vasogenic edema. In fact, if you're a homozygote, it can be up to 70%. So you have to be a little careful when it comes to that. The reason it's also exciting to this audience needs to understand is that this is not the only monoclonal. In fact, aducanumab is one of 4 drugs that are in phase 3 trials nearing completion, nearing approval process. the second of the four. And so, you can kind of, wring your hands on the whether aducanumab should be approved. I think aducanumab, half of the story is a self-inflicted wound on Biogen's part. But the fact is that there are 3 other monoclonals that are in development with better signals. So this is the BAN 2401, now known as lecanemab. This is Eisai Pharmaceuticals drug. And they remove amyloid up to 90%. And they show when they remove amyloid up to 90%, they reduced in their highest dose, 10 milligrams per kilogram every other week, they reduced clinical decline progression by almost 50%, 47%. So it does, as clear, to have a clinical efficacy. The third of the drugs is a drug by Eli Lilly and Company called donanemab. They did a very large study. So the lecanemab was a huge study, 800 people in a phase 2. Donanemab was a sizable study in a phase 2, 257 patients, and they showed almost a 40% decline, reduction in the rate of decline. So the IADRS is a composite score. It's a mixture of CDR, mini-mental, MoCA, and other things. And so what it shows, the IADRS in the placebo group declined 10 points, but in the donanemab group, it declined less than 7 points. So about a 35% slowing in the rate of decline. And that means that was statistically significant. So much so that they actually stopped dosing patients once they got to amyloid negative. And this might be the new future of us. So we need to understand that once they picked patients not on the level of amyloid, they picked them on the level of tau. And they showed that intermediate tau is the best target. They also showed that the patients who got to no amyloid, they stopped dosing. And so we call this now, you might call it induction therapy. And that's why you're seeing it as a potential strategy for the future. And here's, you see the upper panel, this is the paper published in New England Journal, showing that the donanemab group, that's the green line compared to the gray line, significantly slowed the rate of progression, not just in the IADRS, but if you look at all the secondary endpoints, it would seem to work as well. The fourth drug is gantenerumab. This is the Roche drug. The gantenerumab study shows very clearly that they can remove amyloid in a very robust way. They did not hit a statistically significant endpoint on the clinical efficacy signal. They've gone back to do a second phase 3 trial called the Graduate study. They are actually filing. This drug could be approved later this year. The reason this is important is that the phase 3 trial uses a subcutaneous dosing. So the reason this might be very exciting is instead of an IV infusion like the other 3, you might see that this is subcutaneous dosing, could be give more options to patients. What have we learned? We learned that you need to go very early. These are patients in mild cognitive impairment or mild AD dementia, that you have for an ApoE4 carrier. There is some evidence to suggest you might want to alter your dosing strategy, and there will be a consensus position paper coming out on that in the next few weeks. And then you need to look for patients you need to monitor for ARIA. ARIA stands for amyloid-related imaging abnormality. There are 2 types. There's ARIA-E and ARIA-H, and ARIA-E is vasogenic edema and ARIA-H is hemorrhage. I took this off the internet just for the purposes of showing you what a microhemorrhage looks like. This patient would not get a monoclonal antibody. You should only give patients monoclonal antibodies if they have less than 5 or 4 actually ARIA microhemorrhages. So this was just a representative to show you what a microhemorrhages look like. This is what vasogenic edema looks like. I want to tell you that most of the time it's clinically asymptomatic, 75% of the time. And if it is symptomatic, it tends to be mild, a little headache, a little confusion, and it's usually self-resolving without requiring treatment like steroids. We want to understand, though, if you're kind of excited about the idea of giving monoclonal antibodies, which is great, you should think about what needs to be done. Historically, we would just do a clinical characterization of our patients. Now we need to do more than clinical characterization, meaning clinical definition of mild cognitive impairment and dementia. You need to go and get biological confirmation of amyloid. So the question is, how do you do that? One option is amyloid imaging, and there are 4 amyloid imaging agents. 3 of these are approved: florbetapir, florbetaben, and flutamidamol. And the reason this is important is that amyloid imaging works great. However, it is not approved by the United States Medicare and is very expensive to the tune of $5,000 US. So the question is, would you do CSF testing or could you do plasma testing? And that's the things that are, CSF testing has become, in the last 9 months, has become the prevalent because it is covered by US Medicare and it's cheap, $1,200 compared to $5,000 US, and therefore it is easy to do. Now, the question is always discussed is, are we going to see the emergence of the plasma biomarkers? I'm going to skip to Dr. Tabet. I have very little time. I have 5 minutes left. I was going to go into other therapeutics or in the biomarkers. Which direction do you want me to go in the last 5 minutes? You're muted.
Biomarkers, perhaps?
Yes, okay. We'll get to biomarkers. Okay, thank you. So biomarkers. So people, you understand that historically we used Alzheimer's disease as a diagnosis of exclusion, that you had to be autopsy or biopsy confirmed. And that was originally put forth in 1984 and then restated in 2011 that biological evidence, meaning biomarker confirmation, was considered to be suggestive but not required. So what happened since then is this field has split, and U.S. Neurology has not gone for biomarker confirmation as much as the IWG International Working Group. So I'm going to skip to this. The NIA working criteria was considered to be a clinical phenotype with biomarkers suggested but not recommended, whereas IWG said if you have clinical progression with an amnestic component plus any biomarker, CSF, PET, ApoE, didn't matter, you had Alzheimer's disease. And that's what created the framework that has been now the preclinical working group. So the reason I say this to you is that in 2018, we moved forward with what's called the ATN criteria, amyloid, tau, and neurodegeneration. And you have to be A positive to have any Alzheimer's. But you can have tau negative and neurodegeneration positive. So these are the different kinds of formats, but ATN criteria has become the prevalent construct pathologically for Alzheimer's disease. So the reason then why do we need to go for biomarker confirmation? Very simply, it's because the clinical diagnosis of Alzheimer's disease best case scenario is only 77%. That means that in the best case scenario, it means the experts are wrong 1 in 4 times. The actual data suggests that average physician is wrong 1 out of 3 times, 33%, 66% accuracy rate. This is based on the fact that there was a clinical diagnosis assigned to a patient, followed to autopsy with imaging, and showed that the clinical diagnosis is wrong 1 out of 4 times. So the clinical diagnosis is imprecise, and that's why we're looking for biomarkers. This is the historical approach, which is a diagnosis of exclusion. And what you see is that biomarkers could add predictive value, progression indication, or what's called a theragnostic response to treatment. So we have these available, but they're not routinely used, CSF and PET, which we're moving along. If you just say, I can look at an MRI and that's good enough, the specificity and sensitivity is terrible, that the sensitivity and specificity are not good. You cannot just look at an MRI, even though you think frontal lobe atrophy, it must be FTD, things like that, doesn't turn out to be very accurate. I'm a big fan of using ApoE genotyping, but this is not the position of most people. We know that ApoE genotyping is a proxy test of amyloid. So if you're ApoE4 carrier, the probability of having amyloid in your brain is very, very high. And if you have biomarker confirmation, then your probability of progression is overwhelmingly high compared to if you don't. That's the left-hand panel, blue line versus the red line. Of course, we talked about amyloid PET and tau PET. Tau PET correlates very, very well with clinical progression. Amyloid PET does not. So binary amyloid PET, yes or no, it's a diagnostic. Tau PET is a good marker of clinical progression. Tau PET is very expensive, $9,000 US. It is not covered by Medicare, but it is now commercially available. So then we get to CSF testing, and we would test 4 markers: plasma, amyloid, A-beta 42, tau, phospho-tau, and total tau. The CSF validation is excellent. I want to just say to you that the CSF for amyloid and tau is overwhelmingly high, correlates well with PET, correlates with clinical progression, predicts progression to dementia. It has very good validity and good specificity and sensitivity. It's very easy to do in the office nowadays, takes about 5 minutes. And so what I'm saying to you is that the data is very strong. The last thing I want to say, because I know I'm at the end of my talk, is that there is now available the C2N plasma precivity test. This is the first plasma 80 beta 42 to 40 ratio detection. The question has been, will it be sufficient as a diagnostic, or will it be a screening tool? So would the plasma amyloid be what's called the negative predictive value? I mean, in other words, you draw it to enroll if the value is normal, that would exclude the target pathology, but if it's abnormal, then you would do secondary testing, meaning PET, CSF, et cetera. So this is the beginning. There are 2 other platforms that are moving forward. This is the mass spec platform. There's other platforms are Simoa, and the third one is the MagQ IMR platform. So we are seeing the beginning of the plasma amyloid. I think that most people in this field think that it will not be the plasma amyloid, but the p-tau 181 or 217 that will be the diagnostic, and not the plasma A beta 42 to 40. And that is the end of my talk. And I will tell you that thank you, Professor Tabet, for having me. I wish I was actually in the UK, even if the weather's terrible, because it's always better to do these things in person. Thank you.